So we're here to continue on with our Don't Believe the Hype series. Today what we're going to look at again is a case building exercise. So the vast majority of what I'm going to do with this series, as I've already stated, is building a case. Not making firm statements, not saying something is incorrect or correct, but attempting to build the case for why I take the positions that I take, while providing that even though I take certain positions, I allow for a lot of uncertainty within them. Osteopathy and other manual healthcare professions operate under a lot of uncertainty. There's nothing that's absolutely proven with what we're doing, or maybe that's too firm a statement. So there's a lot of claims that are made about hands-on practice that are either unproven or proven to be incorrect, which is why I would make the statement that there's a fair amount of uncertainty. I think it's safe to say that the vast majority of hands-on professions get positive results with their patients. However, the results that are claimed or that are believed may not be the ones that are actually occurring. So there's positive outcomes for most patients. However, some of the claims that we will make are not accurate in the way that we make them. So that being said, what I want to take a look at is visceral osteopathy, or osteopathy in the visceral field. First, I will make a general statement that I understand that a lot of what is said with respect to organs and organ fields, or the concept of organs, completely understand how these organs are suspended, held, and related to other anatomy. So things like peritoneal folds, things like visceral ligaments, attaching to the body wall in some diffused way or direct way. I completely understand that. The general view and the general argument that I've seen made is, well, it attaches to the abdominal wall, so moving the abdominal wall must move the organ. And I understand that as a rationalized argument, and I understand that there's philosophical truth to it, but the accuracy to which we are able to identify most organs, mobilize those organs, or even identify a lack of mobility in those organs is highly questionable. Are there some organs that you can identify with palpation? Yes. Can you identify them with complete accuracy? No. If you can identify most organs that you can identify, if you can identify them, it's a sign of a pathology that should be essentially imaged and further looked at by a physician. Okay, so that being said, as the general preamble, the vast majority of current talk that I encounter with respect to visceral osteopathy comes essentially, or people point back to Jean-Pierre Barral, his co-author on the initial book. Now this is the revised edition that I've pulled up here, but the co-author was Pierre Mercier. Please excuse me if my accent isn't acceptable in pronouncing the names, but we have visceral manipulation. Now this is the revised edition again, as I pointed to. The thing that I want to look at is primarily the diagnostic processes. If you are unable to formulate some form of diagnostic, some form of differential, then any treatment that comes after doesn't follow logically, doesn't follow philosophically, and probably if you are not able to come up with an appropriate diagnostic procedure, your treatment is guesswork at best. Therefore, if you are getting consistently positive results, it's not because of your diagnosis, it would be in spite of it, right? The thing that I want to look at again is the diagnostic portion, and I just want to walk you through some of the general overarching advice provided in this book with respect to diagnosis. And I'll say it starts out fairly solid, but then what ends up happening is the inferential leaps become problematic, at least in my view. You don't have to share my view, but I will provide that this is the view that I'm taking at the moment, and I'm willing to change should you be able to show me that these are not inferential leaps. Okay, so I have it pulled up on my search, which is evaluation. We get to the third or the fourth instance of it, and we get in a little tighter to it. So this is the general overarching advice with respect to evaluation or with respect to diagnostics. We must remember the importance of the physical examination, which is composed of palpation, percussion, and auscultation. When examining patients in the context of visceral manipulation, we pay special attention to certain aspects of the classical examination. Palpation tells us about the tonicity and the walls of the cavities. Okay, so I would say that that's a fairly honest statement. In medical diagnostics, in the physical exam that most physicians will perform, they're looking at essentially differences in tone, right? That is something that palpation they are looking for. They're looking for rebound tenderness as well. So as you push in, and there is evidence in 2020 that I will pull up that they're taught to go gentle, right? Don't just push in, because if you push in fast, then the tension that you'll find or the pain that you'll find may just be the patient guarding. So the medical profession that is not osteopathic is well aware of this in 2020, right? So they're looking for those things. They're looking for tone. They're looking for abnormal things in the abdominal wall. If it falls into a certain region, then that becomes cause for further investigation, right? Percussion tells about the position and size of certain organs. Fair enough statement. The degree of accuracy of identifying the position and size is questionable, but it's not an unfair statement in this case. You can get a pretty good idea based on classical signs, through percussion, the dullness or the tympany. So kind of the dullness or the hollowness of a sound. A lung should sound relatively hollow. Or the region of the lung should sound relatively hollow. The region of the liver should sound relatively dull, right? There's something there that the sound shouldn't travel particularly far. It shouldn't sound hollow. It should sound relatively full. So again, no issues there. Auscultation tells us about the circulation of air, blood, and secretions such as bile. There's normal sounds in the abdomen, so if you're using a stethoscope, you will hear normal sounds. When you hear certain sounds that are abnormal, you know to further investigate. Okay, so nothing problematic with what is being said by this visceral manipulation book at this point, right? We've already discussed the effects that muscular activity has on visceral mobility. That's where there's a bit of an inferential leap. So the general suggestion for earlier on in the book is muscular activity, so muscular tone impairs the movement of the organ. That's a bit of an inferential leap without further research having been provided up to this point. It is imperative to perform mobility tests of the musculoskeletal system. Please refer to the standard reference works for descriptions of these tests. Fry in 1980, Mitchell et al. 1979. We must stress here our belief that visceral restrictions are the causative lesions more frequently than our musculoskeletal restrictions. So what they're essentially saying is that in the regions of organs, if you find a lack of motion, it's because there's a problem with the organ, not a problem with the musculoskeletal system. So they're saying it's generated from the lack of motion or the alteration of motion that you're finding is generated in the visceral system. Again, that's an inferential leap, right? Mobility tests, these normally consist of precise movements to make the organ move directly. The rhythm and direction of the movements are determined by the practitioner. In the case of the liver, you literally lift up to appreciate the elasticity of its supporting structures and the extent of its movement. The inferential leap problem I have here, so if you were to just lift in the region of the liver and let it drop, one of the problems is that people are not built the same. There's varying levels of density of musculature, which will impact how that moves. So a lift and drop, if there's more muscle, you may not get as much movement out of the abdominal wall. If somebody has more subcutaneous fat in the specific region or even below, so somebody who has what could be described as a pendulous abdomen, that will very much impact the ability to make an inference or the validity from a lift and drop, right? You can't say it's the liver. The person has more fat that's hanging lower, so as you lift and drop, there's more weight that's external to the liver that's going to pull down. So again, there's an inferential leap problem just on the simple surface of this statement. Mobility tests are effective as preparatory techniques to prepare areas for diagnosis. While they require less finesse than motility or listening tests, they're still quite important. They provide information about elasticity, laxity, spasm, or structural injury of the muscular and ligamentous structures. Not absolutely a problem there, right? If you're creating movement of the patient, so an external motion, it's reasonable to infer things about soft tissues, right? That's not unreasonable. But to take it deeper to an organ becomes something that requires essentially more evidence. Often these tests are able to help us appreciate what is truly happening and clear away assumptions which may be false. So a differential diagnostic process, no problem with that. But to go back to the concept that we find a motion problem, it's more often caused by the organ that's in the region of the motion problem. That's a challenge. Right, motility tests. There are numerous methods for testing motility, some using the pulse and others differences in temperature. But for us, the most appropriate is listening, the term used by Roland Becker. This admirable word conveys the modesty and gentleness with which you, the practitioner, should manifest. Listening is the essential modality for the evaluation of the axis and amplitude of motility of any viscera. So, my general understanding, and I may be incorrect about this, but again, I'm telling you that this is my general understanding. Essentially, you're in the region of an organ, and you're moving very gently, very slowly. If you are moving at all. So that kind of gentleness, and you're usually in tests that are claimed to be very gentle, you're told to, or it is suggested that you should ignore stimuli that are not the thing you're looking for. So if you're palpating the abdomen, you're supposed to somehow ignore respiration. The abdomen is going to change size as somebody breathes. So you're told to ignore that. Based on the human sensory system, that's not the easiest thing to do. I can't say it's impossible, but it's not an easy thing to do. And there's a lot of noise in that signal. So if you're going to claim that through subcutaneous fat, the abdominal wall, possible layers of peritoneum, depending on where you are, how far back that organ is that you claim to be listening to, that you're going to be able to filter all of a very small motion that you claim to be finding through all of those tissue layers, as well as through normal respiration, that becomes a challenge that requires a lot more evidence, which I don't usually find present, right? So I'm not saying it's impossible, but I don't find the evidence to support the claim as it's made. Right. Moving forward, place your hand over the organ to be tested with a pressure of 20 to 100 grams. How do you measure that? I don't know. At least in practice, you have the opportunity, should you want to train yourself, to essentially get a pressure gauge of some sort, or a kind of a pressure pad that has a readout on the computer, and you can do essentially what's called biofeedback training. So you have a readout on the computer, you have a scale that would go from 0 to say 120, 120 grams. Get used to what it's like to put 20 grams of pressure because you've got the feedback. You could do that, but most of us don't have access to that. Most of us probably aren't accurate enough to understand 20 to 100 grams. It's a nice suggestion, but I don't know how you actually employ that behaviorally in a patient encounter, right? The hand, in some cases, the hand can adapt itself to the form of the organ. The hand is totally passive, but there's an extension of sense of touch used during this examination. Let the hand passively follow what it feels. Slow movement of feeble amplitude, which will show itself stop and then begin again. This is visceral motility, right? So again, the inferential leap, no evidence being provided to suggest that you can feel what they're saying you can feel, what you can feel. So, again, more and more problems with the origin of what is commonly spoken about today with osteopathy in the visceral field as to how you would accurately identify the problems that you're claiming to be able to identify. There are just base surface level problems with the level of evidence and the level of accuracy. Okay, we move over to a newer book that is essentially, if I remember correctly, this was originally in German and now it's in English, or translated to English, Visceral Manipulation in Osteopathy. And I'll get down to where I want to be. Yeah, so deep palpation. So palpation again, so this is a newer work compared to the original Barral work. In palpation of the thorax, elasticity tests are performed at different locations on the ribs and sternum to gain impression of the fascial tensions in the rib cage. So as you're pushing in and letting off, and kind of compression, basically you're squishing the rib cage and you're seeing how it bounces back, and that's your diagnostic. There are multiple things that could be changing that: the tone of the external muscles, the fitness of the patient, the guarding of the patient. If you're pushing on most people's rib cages, depending on where you are in the world, they're just not going to feel particularly comfortable, and they may guard quite a bit. It's also uncomfortable. Having somebody squish your ribs and make it hard for you to breathe is quite uncomfortable. So it's not likely that you're going to find a lot of people, at least initially in patient encounters, that will relax easily if you're squishing their thorax. And even if you're squishing their abdomen, it's probably not the most comfortable for them. So what I want to kind of get into here more is the deep palpation side of this. Deep palpation is applied to the organs themselves. We evaluate for painfulness, differences in tension, position of the organ, tone of the organ. So painfulness, no problem there. Rebound tenderness or tenderness upon initial palpation, no problem there. Differences in tension, no problem there, because that tension could be referred from the abdominal wall itself. It could be lunch. It's hard to say that it wouldn't be. If somebody is extremely full for some reason, then certain areas will be distended, they'll have more tension in them. It doesn't mean it's always the case, but it means it's at least a possibility. The position of the organ, that's a bit of a challenge, because we understand that there are normal differences in people as far as the size and shape of their organ. A very superficial way to look at this is if you have an atlas of anatomy, often they will have plates that are drawings or pictures of normal variances in certain pieces of anatomy. Odds are that people don't have situs inversus, but it could be that they have situs inversus, so organs are flipped in positions left to right. We know that the appendix, the vermiform appendix, is usually essentially in the right lower quadrant. However, it isn't always there. It can essentially be anywhere along the colon. It could be in the same position but pointing up, same position pointing down. You could have multiple vermiform appendices. So there's a lot of stuff that we don't know if we don't have other information. So there's a fair amount of guessing at the start. So you can walk into this and say, that's a liver. It could be a stomach. Odds are that it's a liver if you're on the right, but it could be a stomach if you're on the right, depending on the person. There are varying shapes of the stomach. Some stomachs are very long and descend quite low towards the pelvis. These are things that are known, but you don't know if you're on the outside and you lack an image. Right? So the position of the organ can be an interesting thing, because you could think it could be one thing and you think it's something else because of your preconceived notion of where all organs are, if you don't walk in with the uncertainty that organs could be in places that you don't expect them to be. I have heard of one example of a cadaver that was dissected and the stomach was above the diaphragm, and the person's partner reported, apparently, and this is my understanding of it, that when the person was alive, there was absolutely no stomach issues, right? There was no knowledge that the stomach was above the diaphragm. The reason there could likely be that it was so normal for the person that was just a normal sensation. So I can present to you at least one case where a stomach was above the diaphragm and nobody knew, right? So you have to walk in with this uncertainty. If you walk in with certainty, I definitely found the stomach, then I can point to multiple reasons why you may be incorrect. Walking in with that uncertainty helps, right? So when things don't make sense, you can admit that they don't make sense and you can then go somewhere else. The tone of the organ, that's a hard one for me, because it could be the tone of the abdomen. It could, in and of itself, there could be multiple things going on there. One of the things that they do talk about, which is very nice in this book, caution: if palpation or visceral manipulation triggers strong vegetative reactions, you must stop treatment. If necessary, advise the patient to seek medical clarification. So sweating, discomfort, vomiting, things like that. You push on their stomach and they barf. Call a doctor. Okay, that's very reasonable. I greatly appreciate that. What we get here is this pops up on PubMed. It's called, the title is simply Abdominal Exam, Carl A. Mealy, David E. Manthe, last update February 17th, 2020. And I want to take you to a specific portion of this just to kind of communicate a point. But they do talk about rebound tenderness, they talk about going nice and slow. Let me see if I can find the nice and slow. Yeah, light palpation and then deep palpation. Note to press slowly. Pressing too fast may trap a gas pocket within the intestinal lumen and distend the wall, causing a false positive pain. Feel for softness, firmness, guarding tenderness, and rebound. Attempt to find the point of maximal tenderness. Right, so they do suggest going smooth and soft. Okay, so I've said that. There you go. There is my proof that what I said at least has some validity to it. I'm going to roll down lower into this. So just keep in mind that this is not primary research. This is a guide. Okay, let's zoom out just a little bit here. So the clinical significance of an abdominal exam. In a time of increased technology with CT scans, ultrasounds, and MRIs, it is easy for the clinician to become a technician and rely solely on technology. He is an excellent clinician who develops the hypotheses for the cause of the patient's symptoms. These are based on the chief complaint, the patient's history, and a physical examination, such as the abdominal examination. It is the intelligent clinician who then judiciously orders the appropriate test to knowingly search for specific findings that will either support the hypothesis or force the clinician to reconsider new theories for the cause of the patient's symptoms. The reason I want to read this out is that this is embedded in a guide to abdominal palpation, or the abdominal exam, that was updated on February 17, 2020, and what they're talking about is differential diagnostic processes. They're saying that the physical exam has some uncertainty, or embedded in the statement. I can't say that this is specifically what they're saying, but if you read the rest of it, this is implied. Okay, you have to read the rest of it, and I'm not going to do that because it becomes cumbersome for you to listen to. But embedded within this is that there is some uncertainty within palpatory examinations, and within that uncertainty, you do have enough information to point you to further examination. So, as an example, if you find rebound tenderness or a palpable mass on the right or the left subcostal margin, then what you can begin to believe is that you may have an issue with the stomach, you may have an issue with the spleen. If it feels a little bit like a kind of a pointed tail, it may be the spleen, but that would be splenomegaly. It's very rare that you're going to find on palpation a clear spleen. If you do, and I'll show you this in a little while, there's evidence to suggest that if you do palpate it clearly, it's probably splenomegaly. Okay? What we look at now, accuracy and reliability of palpation and percussion for detecting hepatomegaly, a rural hospital-based study. So this was 3 physicians in a rural region in India who were provided with patients who had ultrasound performed on them to identify whether the liver was enlarged or not, and the findings follow. Okay, and this was 2004. Palpation and percussion are standard bedside techniques used to diagnose hepatomegaly. Ultrasonography is a non-invasive and accurate method for measurement of liver size, but many patients in developing countries have limited access to it. We compared the accuracy of palpation and percussion in a rural population in central India using ultrasonography as a reference standard. So they were comparing. They have something that is known to be fairly accurate in the ultrasound, and then they have something that is known, well, they want to compare the accuracy of palpation because it's more readily available. 3 physicians blind clinical data and to each other's results independently used palpation and percussion to detect hepatomegaly. Diagnostic accuracy was measured by computing sensitivity, specificity, and likelihood ratio values. Interphysician agreement was assessed using the Kappa statistics. Of the 180 study patients, 36 or 20% had enlarged liver on ultrasonography. The likelihood ratios for findings at both palpation, 2.2, 3.0, and 2.5 for the 3 physicians respectively, and percussion, 1.1 for all 3 physicians, as predictors of true hepatomegaly were low. So what they found is when referenced against the ultrasound, it was unlikely that they were to find it when it was known to be there. Doesn't mean they can't, it just means that they're unlikely. Kappa values for inter-observer agreement between the 3 physicians for presence of hepatomegaly at palpation, 0.44 to 0.53, and percussion, 0.17 to 0.33 were low, indicating poor reliability of these techniques. As far as palpation, the 0.44 to 0.53, if I remember right, and we'll get to this later, is closer to fair, but the 0.17 to 0.33 are low, right? The clinical assessment of hepatomegaly palpation and percussion lacks both accuracy and reliability. So if you're in an area where you don't have access to an ultrasound, palpation for hepatomegaly specifically may not be a useful replacement, or as useful a replacement as we would like it to be. We go into a study of the reliability in clinical palpation of the spleen. This is from 1989, so this is older. There's probably newer stuff on this, but this is the one that I'm bringing up just as a general reference, right? Where do we want to go here? The position of the spleen tip in relation to the costal margin correlated well with clinical palpability when the spleen was clearly enlarged. But when the spleen tip was just below the costal margin, it was not always palpable. In some cases, a normal-sized spleen was palpable, whereas non-palpable spleen was not always normal-sized. So we have some problems here. What they're saying is that there's varying anatomical presentations of spleens, and they're sometimes palpable, sometimes not. Usually, if it is palpable, it's splenomegaly. Okay, that's essentially what we want to show you there. We go into a book, Evidence-Based Physical Diagnosis. If I remember right, this is from 2013, And this takes us through a bunch of values, right? So what primarily it's looking at is reliability. So the ability of a test to be agreed upon by all of those who perform it, in this case anyways. So reliability usually is referred to as all of the measurable outcomes. So do you get a consistent measurement? Do you get a consistent outcome when you continuously run this test or run this evaluation? And then also the ability to discriminate between performances. All right, so here we get into the whole deal and a bunch of stats here, okay? So it gives you varying tests and then the values of the kappa values for the inter-rater reliability. And just kind of scroll all the way down to the bottom of the whole deal because it gives a nice readout here. Interpretation of the kappa statistic: 0 to 0.2 slight agreement, 0.2 to 0.4 fair agreement, which is why I said that the palpation with hepatomegaly was in the fair range. 0.4 to 0.6 moderate agreement, 0.6 to 0.8 substantial agreement, 0.8 to 1.0 almost perfect agreement. Okay, and we want to go into the abdomen, right? Into the abdomen as far as inter-rater agreement is concerned. Does that mean accuracy of identification? No, it doesn't. It means that people performing the same test don't agree on what they found. As a proxy, if you don't agree on what you found, it can very easily suggest that you're not accurate or accuracy is questionable. So if it's not a reliable test, if not everybody can come to the same conclusion, then even if some people are accurate, it's not as useful in clinical application because not everybody's going to get there, not everybody's going to come to the same stuff. Depending on what you're talking about, abdominal tenderness, this runs from 0.31, which I believe is fair or low, up to, kind of a decent up to 0.68, but that's a pretty broad range. Abdominal wall tenderness test, 0.52 to 0.81, so that's pretty good. Rebound tenderness, 0.25. That's not so good, right? So using rebound tenderness as a clinical sign for a problem in the abdomen doesn't seem to be as useful as we'd like it to be. Guarding, rigidity, 0.14. So the observed inter-rater reliability of rigidity of the abdomen is very poor, right? And this is when studied in a reasonable fashion. Abdominal mass palpated, 0.82, that's pretty good. So if there's a big lump where there shouldn't be a lump, people are pretty good at finding that and agreeing that they found it. Palpable spleen, 0.33 to 0.75, so that's a big range. Palpable liver edge, 0.44 to 0.53. Well, the liver is bigger, and that's the liver edge, right? So you're going to get some people finding that and agreeing on it. You're going to get some people not finding it, not agreeing on it. So there's a range there. Liver consistency, normal or abnormal, 0.4. Liver firm to palpation, 0.72. So when you're in the region where the liver probably is, and you push, and it's firm, people seem to agree on that. So there's some clinical usefulness in that, right? We just kind of get into this now. Further on in this book, very, very close to this, what you'll find is the inter-rater reliability of images. So it's not the accuracy of the image that they're commenting on, it's the inter-rater reliability of interpretation of the image. And even there, it's not what we would hope it would be. Inter-rater reliability on image evaluation is not perfect, right? So the image is accurate, the interpretation of it has agreement issues. Right? So you have to be able to piece the differences between those. The MRI is accurate. The MRI shows you what it shows you. It shows you things as clearly as it's able, and there's different strengths of MRI machines, so different abilities to kind of get more clear images or higher resolution images. The ability of the person evaluating or multiple people evaluating to agree is not as high as we'd like it to be. So I just found out apparently that my memory card only allows me to film so much video, but either way, what I'm going to do now is go into the final paper that we are going to look at to discuss visceral osteopathy. So we talk about a systematic review. Now, the aim of sharing this is to show what research suggests about visceral osteopathy. So I've shown you some of the problems with the way that visceral osteopathy talks about diagnostics. The diagnostics they suggest aren't necessarily a problem, but the inferences that are made as a result of them can become a problem. Now what we do is we look at this paper, so reliability of diagnosis and clinical efficacy of visceral osteopathy, a systematic review, and we're going to stick in the abstract here on account of the fact that going through the body of the paper becomes cumbersome, which is essentially part of why I ran out of space on my memory card. But what we do here is just take you through that so you understand. Now, before I do that, I will say that the review process or the methodology that was used for the systematic review is an acceptable methodology, and the authors seem to have done a pretty good job. But we take you to the statement that's made for kind of brevity in the abstract. The analysis of reliability studies shows that diagnostic techniques used in visceral osteopathy are unreliable. Regarding efficacy studies, the least biased study shows no significant difference for the main outcome. The main risks of bias found in the included studies were due to the absence of blinding of the examiners, an unsuitable statistical method, or an absence of primary study outcome. Conclusions. The results of the systematic review lead us to conclude that well-conducted and sound evidence on the reliability and the efficacy of techniques in visceral osteopathy is absent. Did they say visceral osteopathy doesn't work? They did not say that. Did they say that you shouldn't try to prove anything about visceral osteopathy? They did not say that. They said that well-conducted and sound evidence on the reliability and the efficacy of techniques in visceral osteopathy is absent. They're saying that the research that's been performed is the problem. They're not saying visceral osteopathy itself is the problem. They're saying the research that's been performed is the problem. I would put forth that one of the reasons we have this problem is on account of the inferences that you're asked to make with the methodologies put forth for diagnosis in visceral osteopathy. You're being asked to make too much of an inferential leap, and then everything that follows that is a problem. So as I said at the top, if you don't have a sound diagnostic process, then everything that you do after that, if you get consistent results, it's not a result of the diagnostic process, it's in spite of it. It's essentially an accident of consistent behavior, right? So if you don't have a sound diagnostic process, then that makes reasonable inferences or that makes valid inferences, then claims that you'll make about what you do become the problem. What you do may be fine, so the methodology that you use to help a patient, the methodology you use to make change that benefits the patient may be fine. The claims you make become the problem. So the central concept here to take away from all of this talking is that the claims of visceral osteopathy are the problem. The methods may be fine, okay? The current research suggests no positive clinical efficacy. It doesn't mean it's not there, it means that you can't find it when you look at papers. What would I suggest as a result of this? Change your claim. So this is something that I've talked about before. The idea that what we do may be fine, but the claims that we make become the problem. So if you step forth and you say that I have a consistent approach that seems to provide consistent results on whatever level, I need to be clear on the level that I'm claiming those consistent results. Is it patient satisfaction? Is it change of length of stay in hospital? Is it change of recovery rate? Is it change in subject of complaint? Whatever the level is, I need to be clear on the level. But I can say that there's a consistency of results. I would say that for myself, there's a consistent distribution of results. Not everything seems to respond in the way that myself or the patient wants it to, but that may be a differential diagnostic process whereby the tools that we are using for the complaint are not the appropriate tools, and then they can go somewhere and find the appropriate tools, be it another complementary practitioner, be it a physician, be it a medical specialist. There's somewhere else to go, but my process would suggest where they should go, so I can build a differential diagnostic in there. So if we step forth and we provide the uncertainty, or we live in the uncertainty and say that we have a consistent process that gets fairly consistent results or consistent distribution of results, and that's fine. Why does it work? I'm not sure. You can stick with I'm not sure, because otherwise you're spreading the hype. Stop spreading the hype and don't believe the hype.